Hi, everybody. Welcome. We get going. Or trick. Great. Want to welcome you all. My name is Sam Brooks, and I am the director of Voice for Quality Long-Term Care. I want to thank you all for joining today on our webinar about how to submit comments on the proposed. As many of you obviously are aware, there's a rule that requires commenting, and we're going to walk you through it today. Know what you need to say, how to say it, and where to say it. So we're really glad to have you here. Just do some housekeeping before we get started. Next. Consumer Voice. Hopefully you know us, but we are the leading national voice representing consumers and issues related to long-term care. We advocate quality of care and quality of life, responsive to consumers' needs in all long-term care settings. We empower and educate and families with knowledge and tools they need to advocate for themselves. Hold on, it says somebody says I'm breaking up here. Just bear with me a second. Can you hear me now? So everyone's agreeing that they can't hear me?
Talk, it's that you were breaking up, so talk and let's.
Is that any better? Is that any better? All right. Sorry. Okay, great. Sorry about that, guys. I got a new computer and it's a little rough. So we train groups that empower and advocate for consumers of long-term care, and we promote the critical role of direct care workers and best practices in quality care delivery. Next slide. This program is being recorded, as you noted at the beginning. Please use we're going to try to get the questions today. We got a lot to go through, but if you do have a question, feel free to put it in the Q&A and we'll try to get to it at the end. You can use the chat feature to submit comments and talk to each other during the presentation. Please complete the evaluation questionnaire when the webinar is over, and links to resources will be posted in the chat box, and they'll also be available on our website. These slides will be available on our website to you after. Next slide, please. We're very excited to have this program today and have two wonderful experts on nursing homes that are going to help walk us through this program. This rule. First, we have Toby Edelman. She's a senior policy attorney at the Center for. And then we have Dr. Charlene Harrington, who's Professor Emerita at the Department of Social and Behavioral Sciences at UC San Francisco. We couldn't really have a better panel of experts. And also we have Jocelyn going to, at the end, be talking about how you can share your comments on this. Next slide. So we're going to go in really quickly. This is, we're going to assume you have some knowledge of the rule. We did a study, we did a webinar on it, but we just want to give you the really the lay of the land of what you need to be saying. We're going to walk through the standard itself, what we believe it should look like, talk about the time frames for implementation and the exemptions they're proposing, how we believe it should be enforced, talk about some of the language of facility assessments, and some language on Medicaid transparency, and how to comment. So we got a lot to go through. Next slide. So upfront, comments are due November 6, 2023, not far away. It's critically important that CMS hears from residents, families, advocates, and others about the importance of a strong staffing standard. The nursing home industry has spent millions in opposition to this, drowned out the voices of residents, have drowned out the voices of family members, of ombudsmen, of advocates, and we really need those voices to be heard by CMS because those are the most important voices in this discussion. So we're just going to be providing, we're not going to be able to cover everything in the rule. It's a lengthy rule, but we're going to highlight what we think is important. And critical to this is your story in the comments, and Jocelyn will talk about this some more, emphasizing your experience. So next slide, we're going to jump right into the the rule, and I'm going to turn it over to Dr. Harrington. Thank you, Charlene.
Thank you. I'm the new 2023 CMS proposed staffing standards are shockingly low. The overall standard is set at 3.0 total nursing hours, and that's a combination of 0.55 RN hours and 2.45 CNA hours. So both RN and CNA hours are below what are what's recommended by experts and research, and it's below the national average. So we're recommending a total of 4.2 nursing hours per resident per day, 0.75 RN hours, 1.4 licensed hours, and that's the combination of RNs and LVNs, and 2.8 CNA hours at a minimum. Next slide. And so what I'm going to do is walk through like the key research studies and the key evidence to support our recommended staffing instead of the CMS recommendations. First, there was the 2001 CMS study that recommended minimum staffing hours for long-stay residents to improve outcomes and avoid selected care problems. And these levels were 0.75 for RN hours, 0.55 for licensed practical nurses or LPNs, 2.8 for nursing assistants, and a total of 4.1 hours per resident day. Next slide. Then there was a 2004 observational study, and they looked at two groups of nursing homes that had higher and lower CNA staffing. The high group had 7.6 residents for one CNA compared to a lower staffing at 9 residents per CNA. And this study showed that the higher staffed homes performed significantly better on 13 out of 16 nursing care process measures compared to the lower staff levels. That's measures like getting people out of bed and helping them eat and helping them toilet. Next slide. Then APT did a study for CMS in 2023 that has partially been used by CMS for their recommendations. What part of the APT study showed of different levels of RN staffing compared to the quality standards. This slide shows that CMS selected the 0.55 RN staffing hours as their standard. But if you look at where the arrow is at the 50th decile, that staffing level didn't even meet the average quality staffing. All 5 levels above that were all significantly better in meeting the quality standards. So we think this supports the 0.75 RN hours instead of the 0.55. Next slide. Okay, in addition, there were a number of studies during COVID that looked at resident infections and deaths. And one study was a study in California where we looked at nursing homes that had the 0.75 RN staffing hours. And they were nursing homes less than 0.75 were twice as likely to have COVID infections. So we know from several studies that increases in staffing, reduced infections and deaths. Next slide. Then there was also another analysis that was done by APT in their staffing report that looked at safety standards. The previous slide was quality standards. And again, if you look at this slide, the data that APT presented for the 50th decile, which would be 0.55 RN hours by the arrow here, didn't meet the average minimal safety standards. So all the levels above the 0.55 had significantly better safety outcomes. Next slide. In addition, APT did a simulation study that looked at the statistical estimated time to complete only five tasks, and multiplying these tasks times the number of times the task had to be carried out for a given set of residents, using a combination of RNs and LPNs. And even though this model was very limited, APT showed that you need at least 1.4 to 1.7 licensed nursing hours per resident day to ensure that delayed or omitted time is below 10%. If a nursing home only had one licensed hour, then that would result in 19% delayed or omitted time, which is unacceptable. So this supports the fact that CMS should have set a total licensed hour time as a minimum, but they didn't do that. Next slide. Okay, in 2000, looking at CNAs, in 2016, Snelly and colleagues did a simulation study for 5 ADLs looking at 7 workload categories. And they showed that you needed a certain amount of time to reduce omissions in basic care below 10%. And they confirmed the 2001 study that you need at least 2.8 CNA hours per resident per day for the lowest acuity residents and 3.6 for high acuity residents. Next slide. So the CMS proposed only 2.45 hours of CNA time per day. And this was the first level that CMS saw improvement. But they failed to look at the levels higher than 2.45. So we clearly saw on the APT research that levels at 2.8 and higher had substantially better outcomes for safety and quality. And if you only have 2.45 hours, the Snelly study showed that 15% of care would be omitted. Next slide. CMS proposed only 3.0 hours, but they also said they would consider an alternative of 3.48 total nursing hours, which of course would be better than 3 hours. But we believe the 3.48 would also be completely inadequate because you would have omitted and delayed time. So we're strongly urging everyone to support a total minimum staffing of 4.2 hours per resident day and urging CMS to set a minimum for licensed nurses, because otherwise nursing homes could lay off licensed practical nurses. So there needs to be a minimum, which would include 0.75 RN hours and 2.8 CNA hours. Next slide. finally, CMS proposed a 24-hour RN staffing, which of course we've been advocating for 20 years. But we need to make sure that CMS specifies, which they have not done, that 24-hour RN care would be in addition to the director of nursing and to administrative nurses. We'd also like a standard of an additional RN on 24 hours a day for every 100 beds. And this is just a list of all the organizations that have endorsed this standard. Okay, thank you.
Charlene, that was great. I wanted to address one question that was in the Q&A because I think it's an important one. Strangely enough, the study authors and CMS try to distance themselves from the 2001 study, despite the fact that it was commissioned by CMS and conducted by the same group. They try to dismiss it by saying it wasn't a minimum staffing standard. But yet, if you look at the standard itself, or you look at the number itself, that was a number that they determined was necessary to prevent compromised care. And also, the point of that study was to determine how much care was needed to comply with the Nursing Home Reform Act of 1987. CMS is trying to say, or APT is trying to say, well, there was improvements along the way to 4.1. But of course there are. There's always going to be improvements when you increase staffing. But the point of that study is below 4.1 residents experience compromised care and increased risk of jeopardy. That's a staffing standard. We want a number that below which care it begins to degrade. So they may try to disassociate themselves from it, but we strongly believe it is very relevant to this discussion. So sorry to. I just wanted to address that up front. We're going to talk a bit about timeframes and how they want to implement this rule. There is two timeframes here, one for the 24/7 RN and one for the minimum standard. They've broken it up into urban and rural, and we're going to talk more about this. The urban folks in urban areas, as determined by the census, nursing homes will have to comply with the 24/7 RN in 2 years from the date of the final publication of the rule. For rural facilities, it's going to be 3 years. For the minimum staffing standard, they're 2.45 and 0.55, 3 years for urban facilities and 5 years. Ostensibly, this could be 7 years before folks in rural facilities experience this staffing standard. It's going to be some more time before this rule is published, and then 5 years. And plus, you have to, this is only enforced under the current proposal through a standard survey or through a complaint survey, and that could be another year. So we're very disappointed with these timeframes. Next slide. CMS, no, back one. CMS has little evidence to support allowing facilities in rural areas to take 5 years to comply with the overall standard. 2023 study showed staffing in both areas to be almost identical. The only real significant difference was LPN numbers, but CMS has not even chosen to implement an LPN standard here. Our recommendation is urban and rural timeframes must be identical. We can't treat rural citizens as second class. Facilities that are in residents who are in rural facilities are entitled to the same amount of care that are residents that are in urban facilities. And to say that they're not and to allow them to experience suffering for years is intolerable to us. This standard should be identical for the urban and rural areas, and it should be phased in. CMS should establish reasonable timeframes with benchmarks along the way that show that facilities are making efforts to meet these standards. One, this will make sure that residents don't have to wait years. to experience some of these benefits. And two, it will ensure that facilities do not wait to the last minute and then try to get a waiver of these provisions. Next slide, please. So one of the other big issues here is they're going to allow facilities not to comply with a standard. They're going to say, hey, your facility doesn't have to provide safe staffing if you meet certain criteria. And we're going to go through these criteria. Consumer Voice and most advocates, I believe, would say they oppose all waivers. We cannot treat residents in certain facilities different than residents in other facilities. It's intolerable and it's unjust, and we can't allow facilities to operate at levels that harm residents. We're very, very concerned about that. It's a two-tier system that could cause harm to residents. So while we oppose waivers, we are going to offer some suggestions on the waiver sort of protocol or system that they have developed. Next slide. So there's 4 prongs to get a waiver, and we're going to go through each one. You have to satisfy all of these to be allowed to not comply with the standard. The first one is based on location. Again, the industry has been very good in convincing people that this is going to be the end to rural facilities. But if you look at staffing generally, it's the same. In fact, we find that rural facilities often staff better than urban facilities. But nevertheless, this assertion by the industry goes unchallenged. So what they're saying is that you must show that a provider population is 20% or 40% below the national average. This is a multi-step calculation that uses the Bureau of Labor and Statistics. So you're going to be in a certain area and you have to show that you're below one of these levels. And the next is the closest long-term care facility is 20 or more miles away. Again, to rurality. And I want to point out these numbers again. These are the numbers from the CMS's own study that document that rural and urban staffing are almost identical, but for the change in LPNs. Next slide. These are our suggested comments from this. CMS should use the 20% provider to population ratio. It should use the lower amount. And we need to eliminate the 20 miles or further away provision. It's not based on anything scientific. Again, rural and urban staffing are almost identical. Rural folks live far away from things. I live in Philadelphia. You know how it takes me an hour to drive 10 miles. And so basing these waivers on something so simplified as geography and proximity, one, isn't supported by the evidence, and two, will assure that many residents will not be getting the necessary care. This should be based on actual availability of workers, not distance or location or other concerns that aren't supported by evidence. Next slide. They have to demonstrate this is the second prong. You have to have demonstrated a good faith effort to hire. You have to have a recruitment and intention plan in accordance with facility assessments, which we'll talk about in a bit. Diligent offers to hire, offering jobs at prevailing wages. Prevailing here means that these are the wages that are offered generally in the community, and job listings and common recruitment areas. Next slide. Our suggestions are comments on good faith provision. The wages should not be prevailing. Average wages for CNAs are abysmal. $25,748 is a median wage for CNA. That is poverty level wages. CMS should require higher wages. They could use a variety of measures. MIT has a living wage calculator. They could use something as a prevailing wage plus 25%. The reason that nursing homes can't hire staff is because they underpay staff and undervalue staff, particularly CNAs, and just allowing them to offer the status quo is not the type of steps we need to increase staffing. Next slide. The third prong is a demonstrated financial commitment. It's a vague requirement that a facility must document the financial resources it expends annually on nurse staffing relative to revenue. This is, I think, purposely vague. CMS is asking for comment on this section. Again, it sounds to us, next slide, what we're going to suggest is some very explicit and detailed criteria. CMS needs to have certain requirements in this section in order to qualify for it. So we need to increase scrutiny on how Medicare and Medicaid dollars are spent, accountability for how money is funneled through companies such as related party transactions and other costs not related to care. We got to look at, they will have to demonstrate and explain any exorbitant home office costs, executive salaries, profits. Additionally, we should explore the idea of requiring 80% of all Medicare and Medicaid dollars to go towards direct care. If you don't want to comply with the regulations and you don't want to provide care at a level that is safe, you're going to need to demonstrate heightened efforts to meet the staffing requirements. And there's no turnover measure in this. We suggest that, I mean, turnover in nursing homes, everyone says there's no one to hire and all this. The average turnover is 52%. In some places, it's as high as 100%. It's not that there aren't people to hire necessarily. It's that people don't want to stay at these jobs, or they're underpaid, undervalued, and overworked. Turnover is a perfect barometer for job quality, and we believe that a reduction in turnover should be a part of this, a demonstrated financial commitment to doing staffing better, excuse me. Next slide. There are several groups of folks that can't get a waiver. If you're on the special focus facility list, you can't. Good news for providers is there's only 88 special focus facilities in the country out of 15,000 nursing homes. So this is really not going to affect many. We are going to suggest that this should be expanded to the eligibility list. There's hundreds of homes on this list that just don't get on to the actual special focus facility list because there's no space. And this is a special program for folks that don't know that states can designate particularly bad performing homes, and theoretically they're supposed to get more scrutiny and more oversight. And here are several violations that you could not have had and still qualify for a waiver. And you also could not have failed to submit staffing data, payroll-based journal information. Next slide. Again, we oppose all waivers. All residents, regardless of geographical locations, are entitled to safe and high quality care. The studies show that below a certain level, omitted and delayed care becomes intolerable and residents suffer. We can't allow that to happen. It's just intolerable. We can't continue the status quo. Facilities who cannot staff at the appropriate level should not be paid by Medicare or Medicaid for new admissions. You should not be allowed to admit new residents and make the problem even worse. There's no requirement that facility create better jobs or invest in staff. Just these vague kind of terms, and turnover is not a factor. So those are our big concerns with the waivers, other than full opposition. We hope waivers aren't coming, but if they do have to come, these are the suggestions that we are making. Next slide, I'm going to turn it over to my esteemed colleague, Toby Edelman. Thank you.
Thank you, Sam. We really want meaningful, helpful staffing ratios to happen. We don't want the numbers that Charlene and Sam have been talking about to be just on paper. And one way to make sure that staffing numbers are actually implemented by facilities is to enforce them. We need to enforce the standards that we set. What CMS is proposing is to use the survey process to enforce standards. Just roll this into the general survey process. Now, we know that surveys are required to be conducted under the reform law on a 9 to 15 month basis. The average is 12 months. Now, during the pandemic, these standard surveys were totally suspended as CMS turned to infection control only surveys. But still, we know that that suspension is lifted and facilities are supposed to be conducting annual surveys. But many survey agencies are completely understaffed and they're not conducting surveys for 2 years and more. So there are many facilities that have just not been surveyed in multiple years. So the standard survey is a problem. Complaint surveys, survey agencies will go in much more quickly, within days if it's immediate jeopardy. But this requires that the person making the complaint knows what appropriate words to use to get the survey agency actually to show up. So the survey process, we think, is a necessary part of enforcing the standards, but not sufficient. Next slide, please. We also know when surveyors go out, I mean, part of the problem with the process, not only does it not happen, but even when they do get there, they often don't cite deficiencies. Many things, if the surveyors don't see them, they will not cite the problem, even if they've been told by the families with documentation, pictures, photographs, ombudsman evidence. They won't cite them if they don't see them. And secondly, state survey agencies call most deficiencies no harm. There are 4 levels of scope and severity, of course, and as we know, most deficiencies are called no harm. That's 95% of deficiencies, 94% of deficiencies, and as a matter of policy, CMS pretty much limits any kind of enforcement sanction, any kind of financial penalty to deficiencies that are called actual harm or immediate jeopardy. So that's maybe 6%, not enough. Next slide, please. And we know from reports by the Government Accountability Office since 1998 that the survey process is very weak. It's very timid. There are dozens of reports. I just put a few on the slide to give you a sense of the titles and the dates. It's serious, and it's been going on nonstop since 1998 that the GAO writes these reports saying survey is limited. Next slide, please. So this is our proposal. We see the staffing requirements that CMS is proposing as 2 pretty separate and distinct staffing requirements. First, there's the staffing ratios for RNs and aides, and we hope that CMS listens to Professor Harrington and all the other people who are commenting and saying we need additional staffing numbers. But there are specific numbers that CMS is requiring, and then sufficient staff, the same requirement that we've had since the 1992 regulations. And what CMS says is if facilities are meeting the staffing numbers, that may not be sufficient based on the acuity of residents. So there are these 2 separate requirements for staffing. Next slide, please. So what we would like to do is have enforcement on a 2-track system as well. Facilities report their staffing levels quarterly to CMS through the payroll-based journal system. We want CMS to act quickly on this information. Move quickly. They know quarterly. If the facility is reporting it has not met the staffing standards, we'd like 2 consequences. A civil money penalty. It could be a designated amount, which CMS has done before, specific amount for not meeting the standards. And it could be based on which staff member is not being, the facility is not meeting. That's one possibility. But maybe even more important is the requirement to deny payment for new admissions. This is one of the remedies under the 1987 reform law. We don't want more people going into a facility that the facility has already reported is understaffed. It's not fair to the residents who are there now. They need to have the staff pay attention to them, and it's not fair to subject additional residents to inadequate staffing levels. So these are the consequences we think should happen when facilities report that they have not met staffing ratios. Next slide, please. And then finally, the failure to meet sufficient staffing, which is still an important requirement, although it's been honored more in the breach than in reality. We want this to continue. And if the standard or complaint survey determines that the facility maybe has met the numbers, but does not have enough staff to meet the needs of its own residents, then it should be cited, and CMS should use the full range of remedies as appropriate. And these are civil money penalties, denial of payment for new admissions, monitors, directed plans of correction, temporary management. There's a variety of things that the government can do. We want to see them use them more effectively when facilities are not meeting the staffing standards. Sam, turn it back to you. Those are the points I wanted to make about enforcement. Thank you.
Toby, thanks so much. I appreciate it. We're making good time. We might have time for questions here. Let's go to the next slide. Good. So there's some new language on facility assessments in this proposed regulation. In 2016, CMS finalized some regulation requiring facilities to do facility assessments. And this is a facility-wide, it's supposed to be done at least once a year, that you're supposed to assess your residents, their needs, and determine if you're have enough staff or have enough resources. It's been 7 years, and I think most people on this, most panelists would say this is proven to be of little effect or use in enforcement or in resident care. We certainly haven't seen it have a great impact. But it's mostly a fault of, I think, enforcement, which we know is certainly lacking. But there are some additions. CMS is hanging a lot of their the success of this 3.0 standard on acuity. The idea that sure, you only have to have 2.45 and 0.55, but you still have to staff to resident acuity. And by acuity, that means their needs. Each resident, we're going to have a bare minimum, but you still have to meet the care needs of all residents. They talk about acuity a lot. This is a basement. You're still going to have to meet the standard. They say that each year you're going to have to do an assessment of your staffing team, how many people you have, how many residents you have, all these really things that sound great on paper. And then you're going to go out and implement it. And then if you don't, we're going to see that and we're going to fine you. And anyone who spent a little time in this space will know that often what sounds good on paper does not translate in practice to the nursing home and to the benefit of nursing home residents. But we're really concerned here that they talk a lot about acuity, but give no model. We know that residents today are much sicker than they were 20 years ago, and that's for a variety of reasons. One, most importantly, being that residents are allowed to stay home with home and community-based services. More independent residents are staying home, which is great. So folks who can't live independently are still ending up in nursing homes, and they have more significant needs, and CMS acknowledges that. So we need a system where we're not establishing just a minimum, but we're establishing a series of care levels that meet the needs of all residents. And strangely enough, CMS does pay facilities based on acuity. There's levels of payment, and the more care that residents need, the more money they get. Some facilities get $1,000 for a resident each day, depending on the needs of that resident. But the CMS does nothing to ensure that that care is actually provided. We're essentially paying for a service, but not ensuring that that service is happening on the other end. Next slide, please. Charlene Harrington, who is my hero and on this call, did a really amazing article in 2020. It's cited right there, which created an acuity model based on this patient-driven payment model. This patient-driven payment model, again, is there's stratified. I think there's 6 levels of payment And what happens is the nursing home assesses the needs of residents to what is something called the minimum data set. They assign they assign an acuity level to that, and then they get paid based on that. We believe that that is a model or something similar to that that must be implemented. There shouldn't be one minimum staffing standard. There should be one for each level of acuity. And we're extremely concerned that acuity will be left to subjective assessments made by state survey agencies. Toby's right. What this is essentially is this 3.0 with this a 3.0 base number, and they're continuing the status quo. We've had sufficient for 20 years. It hasn't worked. This enforcement system and others have shown that they don't know how to assess acuity in facilities. That's why it must be prescribed. And CMS must take a central role in that for it to be effective. So in this section here, I think our biggest concerns are, one, sounds good, you have to enforce it. What is CMS going to do to enforce it? And we all need, at least I do, and others need to certainly work to get the enforcement budget increased. But we have to ensure that these protections, which are so integral to this rule that they proposed, are actually implemented. And there needs to be some guidance on acuity. They can't just leave it up to facilities. Facilities don't know how to do it, and state surveyors don't know how to do it. CMS must provide that guidance. That is why we are proposing, and we believe the model proposed by Dr. Harrington should form as a foundation for that. And speaking of Dr. Harrington, I'm going to pass it on again to back to you, Charlene, to cover these Medicaid payment transparency provisions.
Yes, okay, thank you. Yes, so another important component of the regulations is to require more transparency of Medicaid wages and benefits. So CMS has proposed that Medicaid programs must report at the facility level the percent of Medicaid payments spent on compensation for direct care and support staff. And so, of course, wage and benefit data are useful, but we need much more comprehensive data on revenues and expenses. Unless we have more comprehensive data, the wage and benefit data is not going to be that useful. So next slide. So we are proposing that CMS needs to adopt much more comprehensive transparency requirements for Medicaid. MACPAC, which is the Medicaid and CHIP Payment and Access Commission, made a report this year in 2023 about what is needed for Medicaid transparency. And CMS has not adopted these recommendations. So we would like to strongly recommend that CMS adopt the comprehensive recommendations of MACPAC. And that includes having all nursing home data publicly available in a standardized format that includes revenues and expenses. And these payments should include, there's a list of detailed requirements here, and I don't need to go through each one. But unless we have all of these things, you can't just make sense of the wage and benefit data. So we want to see details on their base payments or supplemental payments, their provider contributions. And we want to see expenses for depreciation, administration, property, and profits, and more details on related party transactions, their real estate payments, and their disallowed costs. Next slide. And so the second component of what we'd like to recommend is that CMS should establish Medicaid direct care spending requirements for nursing homes to increase financial accountability transparency is not enough. So there are 4 states that have developed this direct care spending legislation: New York, Massachusetts, New Jersey, and Pennsylvania, and each one has a little different requirement. Next slide. In addition, CMS recently issued a home and community-based service proposed regulation that would require at least 80% of all payments for HCBS to be spent on compensation for direct care workers. Each state must report to CMS annually on these expenditures and make the information available on their website. So we certainly think that this should also be done for nursing homes. So we would like to recommend CMS set a similar requirement of 80% of nursing home Medicaid revenues to be spent on direct care services. That would put a limit of 20% for administration, property, and non-direct care expenses and profits. So thank you.
Charlene. And next, we're going to turn it over to Jocelyn, who's going to talk about how to make this commenting happen. And then we should have a couple minutes for questions.
I am impressed we're going to have time for questions. I'm excited. Okay, so everyone, we have we can go back a page for a second, or we could stay here. That's perfect. Okay. So we've talked today about all the information that can go into your comments, and you can pick and choose from what you've heard today. But I want to just talk for a minute about how to comment and also why we're commenting. We've talked a lot about studies and data and information today, but at the end of the day, what we're talking about is people. We are talking about a staffing standard that does not go far enough to keep nursing home workers or residents safe. We can boil down everything to that simple fact, and that is why these comments are so important. Next slide. So the first step in commenting is to visit our website, www.theconsumervoice.org. And you'll see that one of the sliders on our website is about commenting on the proposed minimum staffing standard. So click it. And you know what? If there's anyone listening along who feels like doing this in real time, go right ahead and do it. Next slide. So once you click on the slide, you will come to the Consumer Voice comment page. The screenshot you see here is the top half of our page. And you're going to see right there, you can actually see that there is a video there. I'm giving you instructions on how to do this now, but we want to make this as simple as possible for you and for everyone to comment. And in a few minutes, I'm going to encourage you to get other people to comment. So this video is going to be really helpful to you and to them. This video gives very simple step-by-step instructions on how to comment. It is short, it is sweet, it's going to tell you everything I'm telling you, but a lot faster. So if there's anything you forget between this webinar and when you go to comment, this video is a great refresher. It's also, again, a great tool to share with others so they can see how easy it is to comment. So just to refresh what we've talked about, go to the Consumer Voice webpage, click on the slider that takes you to our comment page. And if you want, you can then watch this video with easy instructions. After that, scroll down on the page. Next slide, please. Okay, so here we're going to see instructions on exactly what to do. For anyone who is doing this in real time, as I'm talking, you'll see that the very first thing you want to do, and I hope you can see this because this print is a little bit small on my screen right now, but is to visit the regulations.gov website that's linked right here on our webpage. We encourage you to open that in a different browser window so you can move back and forth between the pages. We have a suggested heading right there on this webpage for you to paste into the comment box. The sentence, you can maybe read it, maybe not. If you can't read it, it says the proposed rule does not go far enough to protect nursing home residents from harm. Short and sweet. Then the next step you'll see is to share a personalized story about why you think the staffing standard doesn't go far enough. And we will come back to that in a minute. And then you'll see that we have suggested talking points. We have gone over these talking points and a lot more in the webinar today. And so you have two options. You can share your personalized story, and then you can literally cut and paste the talking points into your comments. Or, and we encourage this, you can expand those talking points with the information we've talked about today, with the information that you'll find on the slides when we share them with you, so that you're including more content and more evidence in your comments. The more thoughtful, the more well thought out, the more detailed in evidence the comments are that you send in, the better. And that is a big part of why we had this webinar today. So if you can enhance your comments with the information we've discussed, that's ideal. But at the end of the day, if you're listening right now and you're a family member or you're a resident or you're just a concerned citizen who cares a lot about this issue, if you are more comfortable just sharing your story and then using the talking points that you see here, that is fine. What matters is commenting and touching on the key reasons that the staffing standard doesn't go far enough to help residents. And then after you finish typing your comments, you fill in the rest of the form and you hit submit. Next slide. So I just want to show you what the regulations.gov webpage looks like. And for those of you who have submitted comments in past years, you will note that this website continues to get friendlier and user-friendlier pretty much every time we visit it. Remember 2 years ago, it was much harder to navigate, but now it's very simple. And again, you can access this page directly from Consumer Voice's website. I will share the link with you in a few minutes. And you see where it says comment. You literally type your comment right there and then answer the other questions on the site. And I see someone saying in the comments that it's still not great. If you are confused by this website, if you have any questions about any of the content that it's asking for, you can again watch the video that's there on our website. It actually walks you through the regulations.gov website. So watch the video if you're not sure, if you have any questions, and you can also reach out to us with any questions at info@theconsumervoice.org. Next slide. So again, because some of you work for ombudsman programs or organizations and are going to be submitting detailed comments and have been submitting comments for years and feel very comfortable, there may be some people listening today who have never done this before, who recognize that this is like a hugely momentous moment in terms of nursing home safety, and how important it is to make their voices heard. And I want those people listening to feel very, very comfortable with how to do this. So let's just talk again for a moment about exactly what you put in your comment. And just as an aside, so the first time I submitted comments on anything was after I went to law school. It was in my first job, and I was very apprehensive about it. Sending a letter to a congressional representative was like, fine, that felt very normal. But writing comments sounded very next level and something only an expert should be doing. That's totally nonsense. Anyone can submit comments. If something matters to you, you have every right in the world to go to this website and submit comments on a variety of issues. You can look around and see where else you want to be submitting comments, but this is just another way to participate in our democracy, and it is open to everyone. So please, please don't feel intimidated when we talk about this. I also really want to emphasize what you see first on this slide. And I know I said this before, and I know Sam talked about this earlier. You need to include a personal story. I cannot emphasize how important this is. There are actual humans who read these comments, and like with everything else, empathy is powerful. It's why we can put forth all this evidence and data and everything we want, and it won't resonate as much as a story from a resident who has firsthand experience, who talks about a day in their life in a nursing home that's understaffed. That hits people differently, and that's why personal stories matter so much. So include a personal story with your comments. And most of us have personal stories. Both of my grandmothers lived in nursing homes at the end of their lives. This was pre-pandemic. But my parents and I saw firsthand the difference between a good facility and a bad facility. We saw how one of my grandmothers, who was someone who lived with dignity her entire life, was treated at the end of her life because there weren't people who had time for her. My personal story could be a couple sentences about that. And if you don't know anyone who has experienced understaffing, come to our website. We have podcasts with residents who talk about it. We're going to be releasing a video next week with a resident who I actually believe is listening to this webinar right now, who lives in a rural facility. And she talked for just a minute about why the staffing standard as written isn't going to make a difference for her, which is a lot about some of the stuff Sam talked about earlier. But when she talks about it again, it hits a little bit differently because it's personal firsthand experience. But we have those resources if you need them. Again, I think many people have their own story already. And then after sharing your story, share the reasons for which there's evidence, which we discussed here today, about why these standards don't go far enough. Our talking points are right there on our website for you to cut and paste, and all of the information shared by Sam and Toby and Charlene, these slides are going to be available so you can add to your comments from those slides, and you can make your comments as strong and detailed as you'd like. Next slide. And that's really it. That's how to comment. You visit the website, you link to regulations.gov, which is listed right here. You personalize your comments, you use the talking points on our website, which we have available. You include information you've learned in this webinar, and that is it. Remember, the deadline is November 6th. One last thing I do want to mention. We want you to comment, and I realize that's why most of you are here, and many of you are probably going to comment regardless. Your organization or office might be submitting comments. Maybe you've done this a million times, or maybe it's your first time. If this is your first time, we're glad you're here listening. But for all of you, this issue is so important. A minimum staffing standard is something we have needed for decades, and the proposed standard isn't strong enough. The moment we can actually make change is now. So comment today, comment tomorrow, just comment before November 6th, but then go a step further and tell your friends and family to comment. The nursing home industry is coming out in full force. I saw someone write a comment to that earlier, something about 8,000 comments. We need to counter that. So explain to your friends and family why this matters so much, why we need a strong minimum staffing standard to protect nursing home residents. Tell them how important it is, and then show them how easy it is to comment. Again, our video is a great tool, and our webpage is set up so that you don't have to be an expert. You don't have to have commented on anything ever before. It gives you all the steps that I've talked about here today. The more voices we have, the better. So please, after you have submitted your comments, encourage your friends and family to do the same and have them do it by November 6th. I'm turning it back to Sam.
Thank you. That was very inspirational, and hopefully folks are getting the bug to comment. Just want to address, I think a lot of folks, and I'm going to go off script here a little, a lot of people are frustrated with how you counter these arguments that there aren't enough staff, rural facilities are going to close down. And looking at the numbers, the greatest predictor of high quality staffing or sufficient staffing in our analysis is the ownership type. For-profit homes staff so much better than nonprofit homes. Many nonprofit homes are specifically designed purposefully to understaff their facilities and to make money. And we're not talking about 10, 20 minutes. We're talking up an hour difference. And why are they not experiencing the same staffing difficulties that for-profits are? And these are homes that are in rural and urban areas. So I suggest that the greatest way to counter is to challenge those statements with data, with facts, with truth. And so often the industry is allowed to say things like there's not enough Medicaid dollars, facilities are going to close, and people just take it as take it for granted when it's not true. We've supplied you here with significant data today to show you thousands and thousands of facilities are providing proper and sufficient care. Many of them are for-profits as well. So we're going to have a question. One of the questions, and I thought we could put this to Charlene. I think one of the problems with minimum staffing is how can you tell if there's enough staffing in your facility? So one of the questions was, how can family members and potential incoming residents know what the ratio of residents on the floor and staffing is accurate? How do you translate that number into something that you can actually count when you're a resident or a family member?
Okay, well, for nursing assistants, the 2.8 hours per resident day translates into one nursing assistant for every 7 residents on the day shift and the evening shift. And on the night shift, there may be more like 12 to 15 residents. But if a nursing assistant has more than 7 residents for the lowest acuity, they cannot get the work done. So that's a key factor. And each registered nurse and licensed practical nurse should not have more than 30 residents in general to take care of, or they can't get the work done either. So that's a good rule of thumb.
Yeah, and all of these are translatable into, these numbers are translatable in, and I encourage you to look at the citation for Charlene's article, where she breaks it down not only by hours, but by resident to patient, resident, excuse me, to staff ratios. And one thing that I just want to point out before we end is folks in Congress need to hear from constituents that this matters to them. The nursing home industry is pulling out all the stops and contacting all the Congress people and setting up a parade of horribles that is really trying to derail this standard. They don't want a standard because it will close the spigot of Medicare and Medicaid dollars that they enrich themselves on. So we need to contact our members of Congress, both senators and the House members, and let them know that this is something that's important to us. If you're able to do that, that would be great. You don't have to send them a whole letter like this. You can just say, we support staffing standards. So it's 3 o'clock. Again, thank you all for attending. There's a lot. We're going, just to be clear, there's a couple other things that we'll be doing. Obviously, we'll be posting our own comments, which are very in detailed and will be pages and pages. But we're also putting together some template letters for organizations that could easily be adapted as well to individuals. That would be something that folks can borrow from. So stay tuned for that. These are very intricate and complex stuff we need to comment on. It's hard to get it down and boil it down into something very easy in a webinar, but we tried to do our best here. So I want to thank Charlene, Toby, and Jocelyn. Next slide, let's put our contact information up there. This is how you get in touch with us. Please comment. We have to protect residents and workers. And thank you for attending today.